Okay, more confessions. I've never debated anything in my life except for earlier. There are no absolutes in life, and if I lose this debate, I will never be able to step foot in UT Southwestern, Dallas-Fort Worth, my home in Plano, Whataburger, or Rusty Taco. Okay, so explain this to me. Why is it that when I was in Baltimore after colonoscopy, everybody wanted seafood? In Chicago, everyone wanted either Portillo's or a steak. And in Dallas-Fort Worth, all they want is Whataburger. I don't understand that at all. It's sort of like a very, very 24-hour version of McDonald's.
Oh, okay.
Okay, so combination therapy for inflammatory bowel disease. So when we think about using combination therapy for inflammatory bowel disease, I'm thinking in terms of immunomodulator, and in this case specifically the conversations on anti-TNFs, I think there are several things that we have to think about from point by point. First point that we should consider is that we need to acknowledge that immunomodulators alone are beneficial for inflammatory bowel disease. So we've known this since 1962. We've known this for over 50 years when the first reported case that immunomodulators may be effective for inflammatory bowel disease. And multiple studies and multiple meta-analyses have been published showing that immunomodulators alone can be used for the therapy for inflammatory bowel disease. And depending on whether you're a glasses half full or glasses half empty person, you can look at the data and sort of decide for your own. And if you're skeptical, if you're really, really conservative and you're skeptical, you can probably say that I'm not sure about its role for induction of remission in Crohn's disease. I'm not really sure about its role for induction of remission in ulcerative colitis. But looking at the data, at least even with the skeptic's eye, I think we have to admit that from a standpoint that there's enough clinical data from multiple different individual studies and Cochrane and meta-analyses that immunomodulator alone maybe is effective for maintenance of remission for Crohn's disease. It's been shown in multiple studies that immunomodulators alone are effective in terms of preventing or maintaining remission after surgery for Crohn's disease. And again, there's mixed data, but you can make at least some conclusion that there's enough data to at least convince you that the use of azathioprine should be considered in patients with to maintain remission for ulcerative colitis. So again, immunomodulators alone, irregardless of using them in combination with anti-TNF, actually have been shown to be at least useful or in our armamentarium for treatment for inflammatory bowel disease. Okay, so then we think about concomitant immunomodulator and anti-TNF therapy. Most of the conversations this morning were based upon using infliximab, doing therapeutic drug monitoring, and maintaining therapeutic drug levels, and for treatment of inflammatory bowel disease. What we've known for years from the Accent studies, the SONIC studies, the SUCCESS studies, is that patients on anti-TNF therapies develop antibodies to those therapies. We know that up to 13 to 26% of patients develop antibodies to infliximab, up to 17 to 27% of patients develop antibodies to adalimumab. So thinking about it this way, 1 out of every 4 to 1 out of every 6 patients you put on an anti-TNF therapy will develop antibodies to those therapies. So from that standpoint, what we also know from multiple studies is that immunomodulators can decrease the formation of those antibodies in 47 to 75% of patients. And again, we've known this ever since, even with my fellowship at Beth Israel with Richard Farrell getting his K grant to study this. Again, a lot of this data has been around for over 20 years. We also know, for example, very recently, that you can actually give immunomodulators, or one study showed that you can give immunomodulators to patients that have developed anti-TNF antibodies. There was one study by Strick et al. That looked at 17 patients that developed antibodies to anti-TNF. Out of 17 patients that were given immunomodulator therapy after development of the antibodies, 13% had reduction in their antibody levels to 0 and with increases in their serum anti-TNF concentration. So you can actually give anti-TNF immunomodulator to potentially rescue back the anti-TNF effect. From that standpoint, then it goes to point 3. We know that combination therapies are associated with better outcomes. And we've known this since 2002 from initial data from the Accent studies that dual therapy patients had improved remission and response rates through 52 weeks. We also know that in these patients, in multiple studies, that patients on combination therapy are more likely to achieve corticosteroid-free remission, clinical response, and mucosal healing, but that weight-based dosing and really monitoring levels is actually very important from that standpoint. So again, if you're going to think about doing combination therapy, really monitoring levels. But the question is, what level do we use? So we all know when we give immunomodulator therapy, we're giving azathioprine and 6-mercaptopurine at weight-based, most of us start at weight-based dosing. We monitor levels. We look for a 6 TGN level of 235 as sort of a indicator of likelihood of response, not necessarily a straight cutoff level, but it's sort of a cutoff in terms of where we think is going to be a therapeutic response. We are actually just recently published data on 72 patients on combination therapy and correlated the combination therapy 6 TGN level with infliximab trough and antibody levels, and found that you pretty much could keep or that the level of 6 TGN that would correspond to a decrease in antibody formation and therapeutic infliximab levels is about 125. So that it might be that patients don't necessarily need to have a therapeutic or a high 235 6 TGN level on the immunomodulator in combination with anti-TNF. You could actually get away with a lower level and still maintain that, preventing that antibody formation. Point 5 is that when you see patients and I discuss with them what therapies you want to put them on, and you say, I want to put you on immunomodulator and anti-TNF, almost every single patient comes back and says, what about cancer? What about the risk of specifically cancer and lymphomas? From that standpoint, Corey Siegel actually has done always a really good job with that 10,000 person graph that is showing that basically the risk of lymphoma for IBD is about 2 in 10,000, lymphoma in azathioprine about 4, anti-TNF about 4 in 10,000, but the risk of combined is about 6 in 10,000. Again, it's not that much higher than your baseline azathioprine or anti-TNF alone, and that the risk, again, of the concern that patients have is specifically of hepatocellular T-cell lymphoma, which has been correlated with young men treated with combination therapy for greater than 2 years, but keeping in mind that the total number of cases seen between 2001 and 2007 of hepatocellular T-cell lymphoma was 38 compared to 157,000 cases of non-Hodgkin's lymphoma. So its overall incidence, even though the concern is in this patient population, the overall incidence of this cancer is extremely low. So, even if you don't believe what I say, maybe we should just believe what's already been published. So, for example, in 2008, just this year, Lichtenstein came up with the ACG, what was published the ACG guidelines or recommendations for treatment of Crohn's disease, and for moderate to severe Crohn's disease with moderate high risk, in terms of looking at the data that's available, it was stated specifically thiopurines are effective and should be considered for the use of steroid-sparing Crohn's disease. Thiopurines are effective therapies and should be considered for treatment of patients with Crohn's disease or maintenance of remission. Anti-TNF agents should be used for Crohn's disease that is resistant to corticosteroids, strong recommendation. Anti-TNF should be given for Crohn's disease refractory to thiopurines, but also they state specifically combination therapy of infliximab and thiopurines is more effective than treatment with either immunomodulator alone or infliximab alone in patients who are naive to those agents in terms of, and the data they state a strong recommendation, high level of evidence. Maintenance of luminal Crohn's disease, again, they say anti-TNF monotherapy is effective at maintaining anti-TNF-induced remission, but because of potential immunogenicity and loss of response, combination with immunomodulators should be considered. Again, strong recommendation. And although data is lacking in postoperative Crohn's disease patients, for postoperative Crohn's disease, anti-TNF therapy should be combined with an immunomodulator to decrease immunogenicity and decrease loss of response, and this was a conditional recommendation. Same thing, if you don't believe what I say about ulcerative colitis, maybe we should just believe Thamos Dissopoulos down the street, right, at Baylor Dallas. In 2015, the algorithms for treatment of ulcerative colitis were published, and in those algorithms for patients with moderate to severe disease or at high risk, the use of anti-TNF plus or minus thiopurines was mentioned 1, 2, 3, 4 times. Again, stating that using combination therapy with a thiopurine is efficacious, is that it can actually help modulate the anti-TNF effect. So again, from the standpoint of using immunomodulators and anti-TNFs, both AGA and for UC and ACG for Crohn's disease use, at least mention the thought or the use of thiopurines in combination with the anti-TNFs. So the way I think about it from a patient standpoint when I'm seeing patients in clinic is that we really only have, even with the new medications that have been recently FDA approved, we really only have a limited number of medications for the treatment of IBD, which is a lifelong disease. For ulcerative colitis, we've got basically 4 classes if you don't count the calcineurin inhibitors, if you don't count the 5-ASAs, if you don't count the corticosteroids. You've got immunomodulators, anti-TNFs, anti-integrin, and JAK inhibitors. For Crohn's disease, you've got immunomodulators, anti-TNFs, anti-integrins, and anti-IL-12/23 right at this moment. And if we don't consider all therapies and all appropriate combinations, we're not thinking hard enough. We really have to think about using what we have in our armamentarium as effectively as possible to keep our patients in control and to optimize the therapy, to optimize the goal for mucosal healing and keep them in clinical remission. And that's it.